My name is Alan Stein, and I'm a Senior Research Fellow here in Global Health and Public Policy. And we really were very keen to have a really good top-class talk on policy issues in relation to maternal and child health. And we're very fortunate to have right here in Oxford the expert, and I'd like to introduce Professor Marian Knight. I'm going to have to read some of her title, but she's Professor of Maternal and Child Population Health here. She's a public health physician who's doing a lot of applied research. And she's also director of the National Perinatal Epidemiology Unit, which is actually based here in Oxford. She's also the NIHR Scientific Director, that's the National Scientific Director for Research Infrastructure, and the Program Director for NIHR Program Research for Applied Research, for the Applied Research Scheme. That's a massive national role. Marian has done an enormous amount of research, setting up a range of different large policy surveillance systems. The UK obstetric surveillance system is run from here by Marian and set up in 2025. And she also runs Embrace, which is a national program for maternal and perinatal mortality surveillance and confidential inquiries, which itself has had an enormous impact on how we understand maternal death and child death and mortality. Marian also heads the National NIHR Policy Research Unit, which is also based here, which I've been privileged to be a member of and brilliantly led in a whole range of ways. So there's no better person to have than Marian, and we look forward to hearing you.
Thank you very much. I've made the first fatal error of the day, no pockets to put this in, so I hope I'm not going to walk off and leave the microphone behind. So, as Alan mentioned, I have various titles, and I think that the one that you didn't mention, because I didn't put it on my list, is that I'm also the academic champion for policy and public engagement for the Medical Sciences Division. And that's important because I'll come to talking about public engagement versus policy engagement as we go through. So I give several lectures over my time, and I often think about, well, how is it that we drive change? And as researchers, this is typically what we see as the research cycle. So we identify a research topic, we design the study, we conduct the research, we analyze the results, and we publish them. And then we go on to the next thing. And the end product, and this is what our university masters love, are these big papers in journals such as the Lancet and the New England Journal of Medicine. But I guess my question, my challenge, is does that really get us where we want to go? And I was looking for a research cycle that got to where I felt we needed to get to. And this was the closest I could find. The reason I picked this one is because of this box. Work with researchers to look back on how well the study went. Why is that important? Because that's how we find out what impact the researchers actually had. And for me, how we can maximize the impact of our research. Now, for those of you with good eyesight, you'll see in the middle of this, there's patients and the public can get involved at all stages. So actually, I found this on the university, on the Medical Sciences public involvement website. But actually, I think we can think about this in the context of policy and policymakers. And I think we could use exactly the same cycle, but think about how policymakers can be involved in all stages of the research. Because that, for me, and one of the sort of learning points for me is that this is one of involvement of policymakers is one of the main ways that we can maximize the impact of our work. So what about, where do we start? So thinking about policymakers at the beginning, and this part talks about suggesting topics for research, prioritizing research and clarifying the research question. And I guess one of the conversations that we need to have is what is really important. And I often talk to people about what is your so what factor? Why do you do what you do? So this is my so what factor. The fact that 4.5 million women and babies die every year during pregnancy, childbirth, or the first weeks after birth globally. And that's equivalent to 1 death every 7 seconds. And the bottom line is relevant, mostly from preventable or treatable causes if proper care was available. And in the context of a talk about thinking about policy and policy research, that says it all to me. We need to get policymakers on board. I'm just looking at my phone so that I read this quote out correctly. So Mahmoud Fatala, who sadly died last year, but was the president of the International Federation of Gynecology and Obstetrics back in the 1980s. And he said in the 1980s, women are not dying because of diseases we cannot treat, but because societies have yet to make the decision that their lives are worth saving. And that, I think, is again why policy research and working with policymakers is actually essential, no matter what research we're doing, to actually make a difference. I was confessing to Alan, I take a very broad view of what a policymaker is, and for me, the policymakers, by and large, in the health sphere, you can see some of the strategic drivers of the work that I'm doing there on the right. And I think when we're thinking about involving policymakers, thinking before we start the research is as important with policymakers as it is with patients and the public. What are the policy drivers? What's the so what factor? Do we have the right question? I think really importantly is the intervention that we're trying to develop ever going to be feasible to implement? Because if you talk to your policymakers and there's just no way that that's ever going to become part of public policy, you can almost stop there. How quickly do we need an answer? I'll come back to timeliness shortly. As I mentioned, my policymakers, Department of Health, different governments from across the devolved nations in the UK, World Health Organization, 2 MPs on the right. One is the chair of the Health Select Committee in the Westminster government, the other Minister for Women and Equalities. It might be an NHS hospital. The different people who are the users of our research, so the knowledge users, are effectively our policymakers. So as Alan mentioned, I have various research programs, all of which we love acronyms, all of which have acronyms and obviously beautiful logos. My particular favorite is the one on the bottom right. I won't take anyone guessing that that's a program all about children, but it's a fantastic logo. So UK Obstetric Surveillance System is the national program that we can do research around severe maternal complications in pregnancy. Embrace is the program Alan mentioned, looking at surveillance and inquiries into maternal and infant deaths, and then the International Network of Obstetric Survey Systems I will also talk briefly about. So UCOS is a system that I set up in 2005 because in 2004 we recognised that we can investigate maternal deaths, and we have been in the UK by then for about 50 years. But fortunately, we've been relatively successful, and maternal deaths are relatively uncommon. So that means it's less helpful to think about the way we can prevent, to investigate maternal deaths, to think about ways we can improve services. So it was a recognition that we needed more nuanced data about maternal morbidity or severe complications in pregnancy from which women survive. The key relevance to policy and policy makers is that this platform is a national platform. So all studies are population-based, which means that the evidence is more robust to guide national policy and practice. And thinking about impacts and outcomes, I did count those papers that I told you not to think about. So 86 publications. For me, lots of people involved, and so developing research capacity, really important impact. But the bottom line is lots of changes to policy, practice, and outcomes for women and babies. And I'd like to illustrate how involvement of policymakers along the way has really helped some of those impacts. So this was a study we did using that system, looking at women who are extremely obese. As many of you will be aware, our whole population is becoming more obese. And it became clear that clinicians were tending to offer women birth by cesarean simply because they were overweight or obese, because they were worried about what might happen in the emergency situation. So we did a very simple observational study across the whole country and looked at the outcomes according to whether obese pregnant women had a planned cesarean birth or a planned vaginal birth. And actually we were able to show that there were no major differences in the outcomes for either mother or baby. And that went directly into the National Institute for Health and Care Excellence guidance on cesarean birth, where it very clearly says, do not use a BMI of over 50 alone as an indication for planned cesarean birth. The study was published in 2010. It was in the guidance in 2011. And one of the reasons for that rapid translation was actually that the chair of the guideline development group was involved as part of the collaborative team for the study. We did a similar study looking at blood clots in the lungs. So we did a study in 2005 to 6, where we identified some factors which made women more at risk of blood clots, which led to a change in the clinical guidance for preventive treatment to attempt to prevent women from getting blood clots. We repeated that study in 2015 to 16, and you'd be surprised how uncommon it is for things actually to be repeated to see how well they've, whether they've made a difference or not. And the simple answer is that if we look at the overall incidence of blood clots in 2005 to 6, compared with 2015 to 16, no change whatsoever. So I guess the question is, was the change to the guidelines the right thing to do? Have there been other changes, which means that we've got a population that are more at risk for other reasons? The simple answer is we don't know. We do know that our population of women giving birth are older, more likely to be obese. So it could be that the no change is not been an increase, but it's very uncommon for people to actually go back and look at the impact of their actions. I'm looking around the room. Most of you are probably too young to have been terribly influenced by the swine flu pandemic or influenza A H1N1, which came around in 2009 to 10. But at that time, there were concerns that the influenza was particularly severely affecting pregnant women, which did indeed prove to be the case. But what was the problem was that anybody who was not pregnant in the UK could simply pick up the phone up their a helpline, and get given antivirals. Whereas if you were pregnant, you had to go to your GP to actually get those. So it meant that pregnant women were less likely to get treated early. Simple, again, national observational study, we were able to show that if pregnant women were treated within 2 days, they were 90% less likely to be admitted to intensive care with their flu. And as a result, the policy on access to antivirals changed. Alongside this study, we also showed that women who had flu had much severer pregnancy outcomes for their babies. And that was one piece of evidence that led to a change in vaccination policy. So this is the Green Book, which is our vaccination Bible for the UK. And you can see that in 2010, pregnancy was added as a clinical risk factor, risk category for influenza, which meant that pregnant women became eligible for flu vaccination. But I've just highlighted at the bottom that the paper with the results of that study that informed that change were actually not published until 2011. And this is because we were actually analysing the data monthly and feeding them into the government and the Joint Committee on Vaccination and Immunisation. So actually the change in policy came about before the publication. So, you know, thinking again about what I've learned about policymakers during, we're not, as researchers, we tend to think we have to wait till the very end of the study to use the results, but actually emerging findings can be incredibly helpful to guide policy. Sharing them early may mean that they get translated much more rapidly into policy and practice. I have said do that with appropriate caveats, because we do have to be aware that they are only interim, so the data may be complete. We have to be clear to the policymakers that the data are confidential, and be clear where it's not appropriate. I can see David snuck in at the back, so he would want me to say that we're not going to be doing this in the middle of a clinical trial, for example. Think ahead about who you might want to involve. And then I've put here discuss timelines, because if anything, this is probably the biggest lesson I've learned about working with policymakers, is that we have very different concepts of timelines as researchers versus policymakers. So for a policymaker, a long timeline might be 6 months. Whereas for us as a research study, probably the shortest are probably going to be maybe 2 years, 1 year if you're really lucky and you're using some routinely available data. So there's often a disconnect between what we're saying we can do and when policymakers think we might have an answer. So actually having those conversations and being absolutely upfront about what one can do within a reasonable timeline is really important. And here is what forward thinking and by policymakers, and in this case, policymakers in terms of funding organisations can do. So I mentioned a little bit about that study we did around influenza H1N1. Now that pandemic actually hit Australia first. So there was a small wave in the UK in our summer, at which point nobody was ready to do any data collection. So our study didn't actually start till 6 months later, which fortunately was our winter, which is when, you know, we tend to get more flu. But what the funders, in this case, the National Institute of Health and Care Research, the NIHR, recognised was that we probably needed to have some of those studies set up and ready to go ahead of time. So in 2011, they put out a call for what they called hibernated studies and funded about 9 or 10 studies to get ready to set up for in case there was another flu pandemic. So the funding was awarded in 2012. Along the way, there were a few tests of the system, and unsurprisingly to anyone, we were asked in February 2020 to see whether we could modify the study for COVID. So the study all the way along had been planned to collect data on 500 affected women. When we finally closed the study, we'd collected information on about 17,000 women admitted to hospital. And that wouldn't have been possible without a lot of other people helping. And in this case, particularly help from the NIHR Clinical Research Network. So search midwives and doctors in all of the UK hospitals who helped out with a lot of COVID studies. So again, you know, the public policy about having that research delivery staff network really made a difference to being able to do this kind of study. So I think we were asked to activate the study formally on March the 19th, and we activated it on the 27th, on the 22nd. So we were able to literally activate it over a week. Oh, unfortunately, this has all slipped to look very strange. So this is actually the timeline thinking about other types of research and COVID-19. And the key point to make is around April 2020, which is when the first pregnant woman, pregnant or immediately postpartum woman died from COVID in the UK. In June, which has slipped off the screen in the middle, I think it's June, or was it August? It is September. So I'm looking at the big column in the middle. In September, the first trials of vaccines began. Pregnant and breastfeeding women were excluded. And not just excluded, but every woman of reproductive age taking part in those trials had to have a pregnancy test before she was vaccinated with either live vaccine or placebo. How do I know that? Because I was one of them. It's very embarrassing, age 50 plus, to be asked to do a pregnancy test. Why is that important? So on December the 8th in the UK, the vaccination program began for high-risk groups, and the information was very explicit. If you are pregnant, you must not have a vaccine on the basis of they were not certain that it was safe. On December the 30th, so 22 days later, the recommendation came out that pregnant or breastfeeding women who were in at-risk groups could and should get vaccinated. We had no information with which to counsel those women in the time between, because they'd been excluded from clinical trials, but also then, once women were vaccinated, we were not collecting information on their pregnancy outcomes. So we weren't even building up information to help understand vaccine safety. So unsurprisingly, there were very high levels of vaccine safety, vaccine hesitancy. And that meant that when the Delta variant hit, which was much worse for pregnant and breastfeeding women, most women were still unvaccinated, and actually mortality rates were higher. And that, I hope you can see, was the result of quite a lot of policy decisions along the way. This is just showing, and I love infographics, and BMJ Medicine does beautiful infographics. This just clearly shows in the different color the different variants of COVID and how they affected pregnant women differently, with the Delta variant affecting pregnant women, and that was the one end of 2021, more than either the wild type or the Alpha variant. But the good news is that that actually when we were able to collect information about vaccination status, you can see that redoses of any dose of vaccine protected women from infection, but also protected them from adverse pregnancy outcomes such as stillbirth. And that's one of the reasons why I think policies like this are absolutely crucial. And this is the Health Research Authority and the Medicines and Healthcare Regulatory Authority are currently consulting on this guidance in the UK around increasing the diversity of people taking part in research. And it's why including diverse participants is really important. As it quite clearly states, there's a range of communities, groups, and individuals from different backgrounds in the UK. We need to ensure that they're involved in the research so that we can understand safety and effectiveness across all of these different groups. And this is just one consequence of exclusion from research, and that we still have. I think the statistic is there's been 2 new drugs developed for pregnancy conditions in the last 30 years because policies do not enable the inclusion of pregnant women. And one of the other reasons is that there is a fear over litigation in rising from the inclusion of pregnant women in research. And one of the messages that come out of our investigations in maternal deaths is still that medications are stopped due to concerns about fetal exposure. And there's no consideration of benefits to the mother. And this graphic just illustrates the fact that we should always be talking about benefits as well as risks when we're thinking about any decisions around pregnancy. And I guess it's just important to remember that this is the kind, I drew this graphic for the book on the left, and this is the kind of headline that every pregnant woman is reading on a regular basis. I challenge you all actually to go away and look, and you will find even in the last week some scare headline about pregnancy in some way. And our policymakers are seeing the same headlines. So everybody has a mental model of pregnancy and associated research being listed. What is fantastic about, and this is supposed to be a global talk, is that there are lots of other people out there who are interested in pregnancy research, and actually working together from the beginning in a network really does make a difference. So we have lots of colleagues doing similar work, and that again meant that when we were asked to look at vaccination in pregnancy by the European Medicines Agency to see whether we had any information about whether there was an impact of vaccine hesitancy or lower levels of vaccination in pregnancy. We were able to write this paper again over a weekend to demonstrate that almost all of the pregnant or postpartum women in intensive care units across Europe were unvaccinated, which meant the EMA were able to reinforce their information campaign about the importance of vaccination. This has been taken forward by the WHO, who've now developed a whole framework thinking about maternal health research going forward, recently published, and the importance of thinking and setting up international networks so that all right, yeah, okay. Oh, okay, right. It's telling me to speed up. Okay. The challenge is that there's not a lot of funding in between emergency periods to set up those networks. So we as researchers have to do a bit of DIY, but again, credit to the WHO for actually getting on and doing some of this. And we now have a framework for thinking about maternal and perinatal health research during emerging and ongoing epidemic threats, and the vision that I think is probably echoing what Mahmoud Fatala said all of those years ago, to ensure that pregnant women benefit from at least the same level of prevention, protection and care as general populations during health emergencies. I did just want to shout out to Ethiopia, who have managed to set up their own obstetric surveillance system, which I think is a fantastic achievement. So just credit to Abra and the team for setting that up, and who've been able to do some of these find studies to begin to address my so what factor. So just thinking a little bit about I said in this talk I would reflect on how research, policymakers can help research, but also how researchers can help policymakers. And this is the typical way that we think about evidence informing practice. So research would go into a guideline or a policy, and then that inquiry investigation process looks at whether we're following the guidance and whether it's making a difference. And this is just an example of where that's happening the other way around. So this was the investigation into maternal deaths back in 2006 to 2008, which showed that there was an increase in women dying from severe infection or sepsis. But fortunately, as I think I mentioned earlier, the number of women dying are very small. So this was 26 women died over 3 years. And as I'm sure you can appreciate, you can't learn a huge amount from studying 26 women. So we did a national study of women who were severely ill but survived. And we were looking at what it was that was, what were the potential associated factors with their infection. I put the logo of the UK Sepsis Trust on the right here, because just to say that another way of amplifying your messages, amplifying the learning, ensuring things get into practice is working with charities. And the UK Sepsis Trust, off the back of this study, developed a whole series of clinical toolkits, which have been incredibly helpful. Anyway, this study illustrated that different modes of operative birth, so either caesarean birth or von-2s or forceps birth, a vacuum birth or forceps birth, were more common amongst women who had severe infection. So we looked, and there were 96 trials in the Cochrane Library looking at antibiotics to prevent infection after caesarean birth, and only one, a very small study looking at infection after operative vaginal birth, which meant that the antibiotic prophylaxis was not recommended by either the Royal College of Obstetricians and Gynecologists in the UK or by the World Health Organization. So again, a bit of foresight from the NIHR. There was a fast-track process whereby if there was a finding from another stream of NIHR work which potentially could be answered by a trial, there was a fast-track process through to the trial funding stream, and we were able to get a trial funded to look at prophylactic antibiotics. randomized about 3,500 women and showed that a single dose of antibiotic almost halved the infection rate. And fantastic. So a year later into the Royal College guidelines and 2 years later into WHO guidelines, we estimate that that prevents around 1 to 1.5 million infections globally every year. But timelines, it won't have escaped your notice, timelines from that original observation, the WHO guidelines being changed, 2010, the mortality report was published and the WHO guidelines changed in 2021. So timelines too long. There are ways of enabling trial access, and I'm really pleased that the recovery trial did enable pregnant women to participate, and that's because we collected pregnancy outcomes through UCOS, so joining the two systems together really helped. And we put some key messages out from the recovery trial, and actually once we offered women the option to participate, women would participate. The barrier was actually getting to that stage. So the barrier largely around sponsors, regulators, and insurers. And as I mentioned, there's this fear from insurers of needing to pay out large amounts for pregnant women who have been involved in clinical trials and had an adverse outcome. But actually this recent report clearly showed that there was very limited evidence of that legal, of any big payouts being needed for including women in research. So I'm hopeful that that might begin to remove that barrier. Few exciting things still to come, lots of potential for using big data. My slight hesitation is that big data is not always all it's cracked up to be. You do have to be very cautious about using raw data because it's not designed to be used for research, and sometimes policymakers will think that it is the panacea to other forms of research. But there's lots of exciting things you can do. This is just one example where we worked with our health economics team to work out how we could use routinely available data to work out the success for babies having surgery, and working with parents, patients, and health professionals have developed a treatment success score that we can use in big data to then be able to look at variation in practice across different hospitals. So I think I'm nearly finished. Lots of policy impacts you can see, and I was slightly surprised to see the number of policy citations of some of the UCOS work across the globe. Policymakers are busy people, so do use their time wisely, but can be incredibly useful. And I just thought I have to mention mental health as I'm sitting here with Alan. And this is not my work, but some work from other work from the policy research unit. Policymakers won't have time to read your paper, so always give them the bottom line. And visual presentation is really helpful. And don't ever spring surprises, so tell them about things beforehand. And this is just a really nice example from some of the other researchers at the policy research unit of how actually you write things backwards for a policy brief. So you start with, actually, if these people are really busy, just give them the 3 lines they need to know. These are the policy implications. If they want to know a little bit more, you can tell them the key findings, and that comes next. If they're really interested, you could have a little bit about the methods. And if they're really, really interested, then you give them the reference to the paper. But they're not going to be, most of them are not going to read it. So this has all gone funny as well. This is the equivalent of the research cycle, but it's the policy cycle. And as researchers, I think we shouldn't stop informing policy, we should make sure we're helping to plan evaluation of the policy, adoption, implementation, and outcome. And probably that's the bit that we're still poorest at. So what have I learned? Know the policy drivers, recognise how risk environments, the wider environment, may influence policy and practice. Involving those policymakers before, during and after will ensure that the research will meet policy needs, but it will ensure that it's used or emerging results can be used in time-critical situations. Think about the bottom line. Manage expectations around timelines and work together. I was saying to Alan beforehand, I think we should be involving patients and the public before, during and after, and we should be involving policymakers before, during and after. I've put one little graphic on the right here. The reason I put that there is because my other lesson is that you never quite know what is going to have the biggest impact. And that is one small part of a single page graphic that I use to illustrate the disparities in maternal mortality in 2018. And that has led to a huge amount of action from Black women's advocacy groups, policymakers, and we're now finally beginning to reduce the disparity in maternal mortality between women from different ethnic groups and white women in the UK. Thank you.
People who aren't involved in this kind of research, to have made one policy impact in your whole life is an incredible achievement. To make this number is something else. Any questions from the floor before we go to online? Ashima.
Yeah, so I really resonate with the points that you've brought in. I just wanted to give you like an insight about specific problems when it comes to maternal deaths in India. And my information is based on two different aspects. One is that my mother is a government gynecologist, and I think 10 years ago, she was the only gynecologist available in a 250 kilometers radius in a very remote village. That was also very contextualized in terms of gender inequality, patriarchal, and then too many social stigmas involved during the pregnancy. One of them, which was very difficult for me to digest, was that women in a particular tribe in that community were not allowed, if they're pregnant for the 9 months, they weren't allowed to brush their teeth. Because they thought that if they would, and this is 10 years ago, so this is also not 30 or 40 years ago, the information. And they wouldn't brush for 9 months, but that would have a lot of dental health problems. In certain cases, that became a scandal was because then they would have certain bacterial infection, and that led to maternal deaths as well, and before the cesarean as well. And in terms of the information, when it went to the policymaker, local, state, and the national, because of Indian context, because it was such a social behavioral, that was also very difficult for policymakers to intervene, because that would also hurt a lot of religious sentiments, a lot of cultural interferences would have happened. Policymakers at that time until now have, so as to speak, really refrained from even doing campaigns which would be about capacity building or even behavioral change campaigns that happens within these remote areas. So one is obviously that I wanted to know of how do you then as a policymaker, but also as a researcher, look at such fragmented, but also such overlining or arching problems that intervene with maternal health, which data might not be the perfect way of assessing that information. And the second part of it is, sorry, shortly, yes. I also have a health-based nonprofit, and we were working with the government for COVID-19 vaccinations for pregnant and breastfeeding women. The problem was that during the period, the government did not release the data about whether the vaccination that they're promoting, if they have done any information with the placebo or a treatment or a focus group. And it was very difficult for us to even go and promote COVID vaccinations for this particular focus group. Any similarities that were there, did the government here release the data before they informed that pregnant and breastfeeding women should be taking the vaccination? Because in India, 2021, when they released vaccination, only 2023 is when the government released the data that COVID vaccination, there was a P factor of how much impact did it actually have if the women took the vaccination. So very different, but
So I'm going to answer quickly so that other people can have comment, but we maybe talk later. So in terms of your first point, I think it speaks to my point that actually we need public involvement, by community involvement, as well as policymaker involvement from the beginning. So to tackle a problem like the one you mentioned, you have to be working with the community at community level, because otherwise you're not going to make a difference without having both of those aspects covered. And one of the reasons we investigate the care women receive here in depth is so that we can identify factors like that. You won't get that from the numbers. You need to understand women's stories and understand what's happening. I've now forgot, in terms of vaccination, I did mention it. So we actually relied on the US data, so there was quite good data coming out of the US quite early on. So that's where we got our first data about vaccination.
Thank you. So I'll just give one online, there are quite a few. So someone asks, it doesn't have a name, any significant, quote, diverging trends around self-destructive behaviors in pregnant and postpartum populations, such as suicidal ideation?
So I don't have any information about suicidal ideation. Sadly, I was just looking at the data earlier today. Effectively, our rates of maternal suicide haven't changed over the last 10 years. So I think we've still got a way to go. I think mental health services have definitely improved. We've definitely got more access to perinatal. I don't know why I'm answering this question.
No.
More access to perinatal mental health services, but I still think we've got quite a long way to go. The concerning trend that we have seen is that it's affecting younger women. So I do think that adolescent and young adult mental health is going to play a significant.
Thank you. At the back, if you just speak loudly, please. Thank
you very much for your presentation. It's very impressive to see your work. Thank you. My question is, so some of your work has at times, I think, gone a bit against government recommendations and policies. And I'd be curious to hear how you got the funding from the funders and how you managed to convince funders that this work was necessary, that then could change government policies again.
Well, I don't ever feel I've gone particularly against government policy. So I firmly believe that you have to make your case in a paragraph, and I think, you know, making the case on the basis of clear need, and if you put it at the front, it's very difficult for people to argue with.
Yeah, I guess why I thought that was seeing the amoxicillin, the antibiotic treatment, where you showed.
So that trial was brilliant because it was a win-win as a researcher, because if it showed that it was preventing infection, then we had an effective preventive treatment. If it showed it was ineffective, then we could stop a lot of useless use of antibiotics. So actually, it was the fact that it would answer the question both ways in that instance.
I'll come back now. No one online. How symbiotic friendly is UK research policy making around allowance for reliable and valid measures for detecting early child genocide globally in utero and after, any major advances in science of insight for the US and ROW? It's a difficult one.
I'm not sure I have a lot of insight into that one. We, for the NIHR does have a stream for global health research, so there's certainly potential funding sources to look at that, but I don't have an answer for the question.
Was wondering about your personal opinion on sort of lumping maternal and child health care together, particularly in like a research and policy sense. Obviously, they're inextricably linked in that way, but the comment from the head of FIGO, who said, we don't value women's lives, which is why they aren't being saved. Sometimes I feel as if you lump them together, the mother's worth is her life is only worth it because of the child. And you kind of demonstrated that with the medications and stopping medications that might be of greater benefit to the mother. And so I guess just from your personal opinion, how do you feel about them being lumped together? And do you think potentially there is room for them to be separated in the future?
So I don't think we'll ever be able to separate them because obviously it's inextricably linked, and there are challenging decisions and discussions to be had because it's not uncommon that when we're thinking about medications, they might benefit the mother, but we might know that there's a risk of it not being the right thing for the baby. So that's always a balance we have to think about. One of the colleagues I work with is always saying the mother is not a vessel, and we probably do forget the fact that you do need a healthy mother to have a healthy pregnancy. And just bearing in mind that the risk environment and women still do stop medication or are advised to stop medication when actually if they were having a discussion before pregnancy about the safety and what is safest for them and their baby, that's often going to be the right answer. So we'll never be able to separate them, and I actually think pregnancy in early childhood is a huge window of opportunity that we probably don't take advantage of on a public health, population health basis. So I probably wouldn't separate them. Pediatricians in the audience won't fight me.
Okay. I think, did you have a question? No. Yeah. You want to go ahead? Yeah.
Hi, my name is Anna. I'm an MPhil student from the Department of Social Policy and Intervention. My research focuses on early childhood and caregiver well-being in humanitarian settings, especially forced migration. So my question is, what do you see are the most pressing policy priorities involving this population? And if you have any idea of evidence gaps or research gaps that we should be focusing on?
So I think Nicole is here, but Gracie is not. But so for me, mental health is a really important area, and thinking about mental health, domestic violence, intimate partner violence are areas that we probably don't think as much as we should about in those kind of humanitarian settings. I am not an expert, but I can certainly put you in touch with people who know lots more about it than me.
Heather.
Sorry, my name's Heather. I'm a DPhil student at the Department of Pediatrics. I wanted to pick up on what you were saying about understanding the women's stories and like the kind of narratives behind the data and the importance in kind of speaking to policy in that way, and how much of your research involves like mixed methods and qualitative work to really pull that out.
I'm smiling because Lisa, who's the qualitative researcher that I work most closely with, is sitting at the back there. There was a fantastic editorial in JAMA years ago now that was entitled Narrative-Based Medicine and Not All. So for me, you need both. You need the statistics and you need the stories, because policymakers are people, and it's actually the human stories that get through, but you support it with the statistics behind. So I firmly believe you need both. Is that the right answer? Is that the right answer, Lisa? Thank you.
We've got time for a last question. There's one, I'll just take the online one, which is a nice, okay, go ahead, yeah. Nothing good.
The surveillance systems that you showed. So in terms of the sample size, since some of your research has very direct consequences in terms of policy, how do you ensure that sample size is large enough and that it's representative of population, and at the same time that you have large enough subsamples of minorities and vulnerable groups? How do you do that in practice?
So the advantage of this surveillance system is it's national, so it covers every hospital in the UK. So that is the advantage of it being population based, so that you know that what you're getting is the whole population in the UK. So I do think it's important that one thinks either on the basis of a whole region or a whole country to get the valid data, so that you can look at the differences between different population groups.
Okay, I'll just take the last question. It's actually similar to Anna's question. Based on your research to date, what single policy would you like to see introduced to improve maternal and child population health? What single policy?
So the single policy is the one around inclusion. It's making sure that pregnant women are included in research from which they can have the potential to benefit.
Marian, thanks very much. I mean, what a wonderful talk. You're not going to get clarity like this very, very often. And someone who's produced so much wonderful research has an impact on policy. But I think one of the great lessons for me is to prepare in advance, to have all these large surveillance systems in operation, allows you to have research in action all the time, but also to piggyback research when you need it, because the system is there. And I think that's really been the secret of your success, if what I can say. And thank you so much. We have a chat to Marian. There should be a chance to follow up chats with Marian. I know you have to go quite soon, but a bit of time to chat.
Yeah.
Good. Thanks very much. Oh, brilliant. Absolutely.